Bismillahirrahmanirrahim. Hi everyone. This is the last video regarding the introduction to point of care ultrasound. We're gonna touch on the artifacts that can be useful in ultrasound. One slide about the requirement for billing, and one slide about some of the resources that you can use when you start learning about the point of care ultrasound. So let's start. So compared to, for example, CT scan and MRI, we always complain about finding artifacts in these images. In ultrasound, actually, artifacts can be useful. They're not 100% all the time useful, but most of the time, actually, they are useful. And they can help delineate normal anatomy from different pathologies. So, for example, during lung examination, one of the normal artifacts is called the Airlines. And the presence of airlines usually during lung examination indicates a well-aerated lung. So a subject who is healthy, when you do a lung ultrasound on them, you expect them to have these artifact airlines. Also, they can be found in patients with other conditions that can lead to a well-aerated or even hyper-aerated lungs, like patient with asthma, patient with COPD. So these A-lines are part of what's known as reverberation artifacts, and it just happened because of the quality of the beams of the ultrasound and the fact that when you are examining a highly reflective two surfaces, in this case the visceral pleura and the parietal pleura, which are in healthy individuals like parallel to each other, and they are very hyper reflective. They reflect most of the ultrasound beams, not all of it, but most of it, as indicated by the red arrow here. But some of the ultrasound beams is not going to be reflected, and they will penetrate the pleural surface, and then they might be scattered back by the air. And we know that air is generally considered to be the enemy of ultrasound because it tends to scatter the beams all over the place. So this reverberation will lead to formation of what looks like another A-lines, and there's another pleural line, sorry. And these A-lines, so for example, this is the first A-line, and this is the second A-line, and this is the pleural line here. So the distance is kind of constant between the pleural line and the first A-line, and the first A-line and the second A-line, and so on and so forth. And the usefulness of this A-lines is not only indicate that the lung is normal or well aerated, or for example hyper aerated in asthma or COPD, but also it's when you're doing your lung examination, you really want to move the probe and fan the probe, or do like angulation of the probe, to be able to put the probe in a kind of a perpendicular position, and this is where you can see the A-lines better. So you can't really say there is no other pathology if you're really not able to see some of the A-lines. Now, sometimes due to presence of pathology, the A-lines might be absent, but usually even in these situations, you can see at least some of these A-lines, and there's other findings that might overlap the A-lines, but to the most part, you still should be able to see some of the A-lines. And once you see them, then you know that you're perpendicular to the lung surface, and that's the right position to do further examination of the lung. So this is part of the reverberation artifact, and there's other reverberation artifact, as we'll see. Another reverberation artifacts are really important ones. They're called B-lines. And basically, during lung examination, when you're looking at the pleural line, which is basically the visceral pleura and the parietal pleura sliding against each other in a normal person, like we see here. This is the pleural line, this is the pleural line, this is the rib, this is the rib, and this is the shadow behind the ribs. And this is the lung tissue basically. So in normal lung examination, you would see the sliding in the pleural line, and sometimes you might see like really very fine lines called cometails. These lines sometimes might extend a little bit lower, and they might be called the Z lines. But sometimes in certain pathologists, you might actually see these vertical lines coming all the way from the pleural line all the way to the end of the screen. And this is one of the important characteristics of what we call the B lines. And B lines are actually a result of reverberation as well. So basically, B lines should come from the pleural line. They should be vertical. They should start from the pleural line and end all the way down to the bottom of the image. So if you increase the depths, you still should be able to see these B lines all the way down. Because they originate from the pleural line, they usually move with the movement of the pleural line if there is normal sliding. If you see normal sliding in the pleural line, like we'll see when we talk about the lung examination, the B lines also should move with the pleural line. Now these B lines, sometimes if you do lung examination at the bases, they might be like 1 to 3 B lines. These might be normal. But if you see a lot of B lines, specifically on the upper anterior lung, this is abnormal. And the most common cause of bilateral B lines on lung examination on the upper anterior lung is pulmonary edema, most commonly cardiogenic pulmonary edema. But other causes include non-cardiogenic pulmonary edema, like you will see in ARDS. Patients with COVID-19 commonly have these B lines. There might be some subtle differences between the B lines seen in cardiogenic versus non-cardiogenic pulmonary edema. Maybe we'll talk about that in another video. Also, the characteristics of the pleural line can also help decide whether these B lines are due to cardiogenic versus non-cardiogenic shock. But this is a different topic. But basically, you can see them in pulmonary edema. You can see them in transudate or exudate from hepatization due to pneumonia, for example, any type of pneumonia. Pulmonary fibrosis also, especially if you see it at the bases, that also can give you B lines. So they're really not very specific to cardiogenic pulmonary edema, but cardiogenic pulmonary edema is definitely one of the most common causes of B line that you will see in the general practice. And these B lines are as a result of reverberation artifacts, and they're very helpful diagnostically. Another artifact is called the mirror artifact, and these are usually reflection of the ultrasound beam from a strong reflector. In this case here, for example, you see the liver. This is the strong reflector surface, which is the diaphragm. So when this highly reflective structure reflect the ultrasound beam, so back to the probe, they might create actually like a mirror image beyond that highly reflective surface. So again, this is kind of a schematic representation of this. So for example, here, this is a liver, this is a diaphragm, and you see this is part of the portal vein, hepatic veins, and you tend to see reflection of the portal vein here. Now, they might seem to be like another liver, so to speak, beyond the diaphragm, but of course, this is a lung, and as we all know, again, it is the enemy of the ultrasound. But sometimes you might get this image if really you're doing an examination of highly reflective surface, and this image, you just have to kind of be aware of this artifacts, so that when you see it, you realize that, oh, this actually looks very similar to this structure above the reflector surface. So this is probably a mirror artifact, and there's no vessel here. So this is really important. Sometimes, this can be confusing in someone who is doing ultrasound for the first time, and you might not realize that this is, you might think that there is a pathology here or a structure here, but there is not. It's just a mirror and artifacts. Some other artifacts include the acoustic shadow. We briefly touched on this before. So the acoustic shadow is seen distal to a highly attenuating structures that reflect, scatter, or absorb the majority of the ultrasound waves. And in this case here, this is a lung examination. This is a rib. And the rib, because it has calcium in it, it reflects a lot of the ultrasound beams. So behind it, you will not see really, you just see a dark shadow. This is the acoustic shadow. And this is a rest of the lung here. This is the rest of the lung here. But, you know, this is why when we do lung ultrasound, we try to keep the bone or the ribs at the side so that we have the lung tissue in the middle instead of the acoustic shadow. So keep that in mind. You know, this acoustic shadow can make the examination a little bit difficult if you cannot avoid them. And this is again a schematic representation of that artifact. The posterior acoustic enhancement is seen distal to fluid-filled structure. For example, here, and if I'm assuming this is a gallbladder, and this is really kind of the most common, the urinary bladder and gallbladder are the most common two structures that you might see this artifacts in lung exam. So basically, this is a fluid-filled structure. Let's assume it's a urinary bladder or gallbladder, and then behind that structure, there's like a hyperechoic areas. It's really like bright area of white ultrasound beams. This is called posterior acoustic enhancement or acoustic enhancement, and this is also happens because of the presence of the fluid inside of the structure that kind of absorbs most of the ultrasound beams. Now, for example, in the examination of the gallbladder, and also to lesser extent in the urinary bladder when there is stones, the stones, especially they have calcium, they will tend to reflect some of the ultrasound beams, and they might create an acoustic shadow crossing this posterior acoustic enhancement. So it's really going to be, as you can imagine, it's going to be very clear because the acoustic shadow is black and the acoustic enhancement is white. So if you see like a triangular shadow here, then you know there is a structure on that fluid-filled structure inside of it, causing that acoustic shadow. And most of the time we assume that this is a gallstones, because sometimes you might not see the gallstones clearly, sometimes you might, but in almost most of the cases you will see the acoustic shadow. So in this case, the artifact is actually diagnostic for the presence of the pathology, and that's why, you know, artifacts are useful most of the time, not always, but most of the time during point of care ultrasound or in ultrasound examination in general.
So when it comes to billing, I don't think it's really very important at this point, because I think it's something that we maybe think about in the future when people are more familiar and they're more comfortable with using the ultrasound or POCUS. But, you know, something to be aware of, you actually can bill for your limited ultrasound examination. In the inpatient, in the outpatient, wherever you do it, using your device, using the hospital device. Of course, there will be like some change in the coding and billing if you're using your own device versus not using your device. But anyways, there are certain requirements that you need to fulfill to be able to bill for your exam. So of course, basic data is always there: the patient name, age, gender, MRN, date of birth, time and date of your exam, and then what's the indication why you're doing the examination. For example, you know, assess the volume status in patient was possible dehydration, and then you describe what you're seeing. You know, is this like complete exam of the IVC or complete cardiac exam or limited cardiac exam? And then what are your findings? You know, this image shows, or the video shows, an IVC of 2 centimeters that collapses more than 50%, for example, which might indicate dehydration. This is kind of your impression. And then, of course, it's very important that you make sure that your image is actually stored somewhere, so that in the future, if anyone wants to review the image, it's available in the electronic health record. All right, so some good news. There's actually a lot of resources that you guys can utilize when you start learning about, you know, POCUS or bedside ultrasound. You know, in addition to the free videos in Google or YouTube, there's other educational resources that's also available for you. For example, you know, Access Medicine, you have free access to that. They launched this new book a few months ago about, pocket guide to POCUS. It's actually very nice, very good material, a lot of videos and images as well. Also, the ACB, they also has a lot of CME modules about point of care ultrasound, and is also free for members. And Butterfly, they actually did a good job creating a lot of like short clips or videos for many like really POCUS examinations, and these are actually available in their website when you log in, or I think it's also available in your device, so you can always look at those when you're doing your examination. For those who are like really interested in point of care ultrasound, this book is actually really nice. I think they launched the second edition. I had the first one. It was much cheaper. It was $20 or so, but now I think it's about $80. But it has online version, so you can have like a lot of videos that you can see, and images as well, in addition to the hard copy if you want. So I'm sure there are many others, but these are the ones that I really found very useful. All right, so we came to the end. I really hope that you guys get some benefit out of this video. We touched base the ultrasound knobology really quick. Knobology is basically a fancy word for like how to deal with the ultrasound keys and knobs, which is actually made much easier nowadays because of the new devices. We talked about the different types of probes. We talked about the principle of acoustic impedance. We talked about some of the basic ultrasound modes. We went through the gain and what it is, the depths, orientation, and then really just quickly on the artifacts and how useful they are in ultrasound. Just a note about the billing, looking into the future, and also some resources that can help anyone who wants to get better on the ultrasound. But of course, the most important thing is really practice, and practice. So I hope I'm gonna see you in other future educational videos, and have a good and nice rest of the day. Bye bye.